hear me vizuri?
Yes, you are very audible.
Okay. So I am a lady. I was born and raised in Mombasa, somewhere called Mshomoroni.
Mhm.
I went to I studied in Mombasa primary. And then in high school, I went to Bura Girls National School. It's in Taita. It was a Catholic school. And then
Mhm.
after high school, I went to Kenyatta University, main campus. I did bachelor's in psychology, majored in psychology, and then minored in sociology. I did that from 2018 to 2022, around June. Yeah, I completed my coursework and then did my attachment at Moi Teaching and Referral Hospital. Yeah, and then after that, I went to Faraja. Faraja is a cancer center. Yeah, it's a cancer trust fund for patients who do not have the financial capacity. It's just an NGO that offers services to the patients. So I volunteered there for a while I did my attachment at referral. It's located in referral, Chandaria, first floor. And then after that, now I got my internship at Eldoret Oncology Associates, where I practiced with cancer patients for the last 1 year, and now I am a psychologist, the counseling psychologist. Yeah, I hope I've
Wow.
answered your question.
Yes, you have quite well, and you're doing well so far. I'm just curious, did you grow up knowing you wanted to be a psychologist, or was it something that triggered your interest in psychology?
Hmm. Well, even after high school, I didn't even know what I wanted to do actually. You know, there's this time that we were doing, I think in Form 4, yes, early Form 4, we were doing these registrations, and then I actually applied for criminology. I do. And then I wanted to do criminology. I didn't even know what that is. It sounded cool. So, but when I was joining school, I didn't know what I wanted to do. So when I was doing the revisions, my dad told me to apply for teaching. So I did, and then I told myself I was going to get the placement and then change to something else because I didn't want to do education. So I applied for education arts to become a history CRE teacher. And then my admission letter came, yeah, Kenyatta University now. It came with Bachelor of Arts instead of Bachelor of Education in Arts. So I mean, at first it was confusing with the orientation, but going to the first classes, the initial contraction with psychology, I mean, it just clicked. And yeah, here we are, 6, 7 years later.
That's an interesting story from criminology to CRE to psychology. Look at that.
Yeah.
Okay, that's nice. So, and then you so let's say, from what I'm understanding is you you got into psychology by chance. By do I say by chance or by luck, or because now I don't know what to say about it that pulled you to it.
Well, I think this is cheesy, but I think it's destiny.
Yeah, yeah. I'd say so
I
too.
yeah.
Wonderful. So, okay, fine. So, destiny brought you to psychology. What was your very first experience now that destiny has put you on psychology that you didn't even have an idea is something you wanted to do? How was your first experience with the psychology world?
The first thing when I was doing my attachment in referral, my teaching, the first day I went to the department, the psychological department, and then I found my supervisor, and then he had okay the whole day, my whole first day, I didn't see any patients. I was just familiarizing myself with the environment. So he got a patient around. He was on call, so he got a patient around 3:30 ish in the evening. So he told me, Faith twende. And I didn't even have my rotations yet. I didn't even have anything. So following him to the ward, he was going to do a consent session. When before a patient afanyiwe any procedure, we have to do counseling. Whether so
Mhm,
that was consent for diagnosis. So it was a bedside session. So the counselor was doing the bedside session. Spectating, so to say. So the next bed, the next ward was a corpse that was being taken out to the morgue. And this is my first session. And the other counselor is just carrying on with the session. I didn't even concentrate in that session. I kept on looking at the morgue and what the mortician was doing.
mhm, mhm. Wow.
Yeah, and then we had to redo the whole session. I had what he was doing later after he was done with the session because I didn't even
Mm.
get anything. My focus was, this is my first time in a clinical setting, so it was something.
First time umeona
Yeah.
maiti. Wow. Okay. Interesting.
Yeah.
So would you say from there is when I mean, if it were me, I mean, that would be the end of it. I mean, I'm going back home. I'm done with all that. What made you stick around?
Well, also, another thing is when I was still adjusting. One of my earliest sessions, the psychologist I had, or my supervisor, that was a lady now. She told me, sahau kila kitu umesoma shule, sijui maneno ya cognitive, maneno ya nini. Like, why should I forget my coursework? I mean, hiyo ndio imenileta hapa.
Mhm,
And then
mhm.
sasa now seeing structure of of um of the actual session. And also now that that statement was scary because telling me to let go of my coursework so that I can practice. I mean, but now it was intriguing because if I'm not doing my coursework, what am I doing? So I think that kept me, made me stick around to find out. So
Wow, you're such a
I
strong
did
lady.
stick.
You're such a strong lady. You're a strong woman. I know everyone listening in are just looking at you and their head because what you did there was your inner strength. You kept on going. You're being described courage. You're being shown a dead body the very first time. You should patch yourself. I mean, you're doing your very first event here. You see, you're a lady of firsts.
Yeah, yeah. Well,
Oh,
so
wonderful.
far,
Mhm.
so yeah.
Mm. Okay, now let me now now we've known who Faith is. Now Faith is in the cancer uh, care. I think cancer care. I mean Forgive me if I use the wrong terms, but
It's fine.
I'd like to know how is your experience talking to a cancer patient? Let me start from there.
Um, yeah, okay, this is also another experience. So when I began my internship, the other psychologist I found there, he told me the same thing. He told me to forget what I was doing in referral hospital, to put everything down. And I mean, I have to put everything down that I've been learning for the last 3 to 4 months. So I began with, of course, spectating,
Mhm,
not having a
mhm,
clue what we're doing. My supervisor was actually really encouraging, because he gave me like a list of expectations of what to expect, of what to do. But of course, most of the experience comes with the job. So he
mhm,
told me structure of the sessions, the objectives, what to expect from patients, how to handle patients in session one, in session two. This was different because this is a private setting. And
mhm,
also in referral, because it's a public hospital, mostly follow up, we did what we could do. The most we could do is just call a patient, and most of them didn't come for more than 3 sessions. But with Eldoret Oncology, we're seeing patients even up to 12 sessions. You're journeying with a patient from session one, from the first day they get a diagnosis till when they complete their treatment, even when they are done with treatment. And that is, for some of them, it's like more than 6 months, more than even a year plus. Yeah, so the experience it's really fun, has its moments.
okay.
Yeah.
So, I know cancer is quite a scary condition for one to have. How would you say the
Yeah.
mental status of a person who is told that they have cancer? How is their mental status the very first time the doctor tell them that you have a cancerous? I'm not a doctor, man. That's all I can say. Cancerous something.
A cancer. Okay. So, our cancer patients usually present with different mental diagnoses. Well,
Mhm,
for a new diagnosis, it's mostly anxiety, because they have that fear of the unknown. Also, they don't know what to expect from treatment, from the management plan that the doctor is going to give them. And then
mhm.
also, an African setting. So most of us, tukisikia cancer, death sentence.
Yeah.
And yes, actually, the first few sessions, like the first and the second session, mostly we try to debunk all that, all the irrational beliefs that patients have about the treatment, about the diagnosis. We do psychoeducation. We tell them cancer is treatable, there is treatment, and this is what you should be doing while on treatment, the do's
Mhm,
and the don'ts, so that you can deal with that anxiety. Because the fear is usually of the unknown.
mhm,
Moving to the subsequent treatments. Now, depending on what happens during treatment, because there are several things that come with
mhm,
diagnosis and just cancer.
mhm,
Like
mhm,
you get this because of the diagnosis. They blame the patient because maybe they don't have family history of cancer, or they don't understand the risk factors of cancer. So that is why we do the psychoeducation. Or some of them, they maybe the patient was was very demanding as a father or as a mother in the household. So when they get such a diagnosis, the whole family deserts them. So, and also the financial burden. Cancer is one of the most expensive chronic illnesses to treat. So because of the financial parts, we get stress, chronic stress. Some, because of the family breaking, they get to depression and some complications of the diagnosis. When they're told they have cancer, and some maybe their mobility is restricted, they cannot do these self-care activities from themselves. If maybe they cannot feed themselves, or they cannot go to the bathroom themselves, or they cannot take a bath on their own, or maybe they're placed on bed rest, that can lead to depression. Yeah,
Ah,
so those are some of
okay.
the
Wonderful. So
issues.
maybe the final question before I share your presentation that you have for us, then we jump into Q&A, is in your own
Mm-hmm.
opinion, I know mental health is it's a wide area, and I'm just
Yeah.
curious, when it comes
Mm-hmm.
to mental health, a person who's depressed out of their own personal issues, could be love life, could be work related, they're just depressed, things are working out, and maybe the worst case scenario, they want to commit suicide. A person in such
Yeah.
a mental state, would you compare their mental state to that of a person who's been told they have cancer stage 4? I'm just curious if there's any relation or there's a difference.
No, there's no difference.
Mhm.
The only difference is the predisposing factors or what caused them to fall prey to such mental illnesses.
Mhm.
Because even the diagnosis is the same. The
Mhm.
criteria for depression we look at, it's the same for every patient. Only
Mhm.
that, of course, now the management is going to be structured differently because we're going to work with the patient. We cannot use the same analogy. Maybe for this patient, this type of therapy works best. And maybe for the other patient, we can use a different type of therapy. But for to diagnose a patient, it's the same criteria for all of them, for both of them. And the symptoms that present with, they are all the same.
They're all the same. Okay. So any do it yourself things someone can do, let's say if they're feeling they want to give up, they are almost falling into depression, what kind of things can they try and do, that is if they still have control of their body system? I understand once you're depressed there's some chemical imbalance in your body, so you really don't cognitively make decisions well. So any remedies that somebody can do? I'm trying to be a doctor, don't even laugh. That's the best I can do.
No
Yes.
depression, no.
Mhm.
Okay, with depression, first you can seek help. Yeah, you can get a professional like a therapist or a psychologist or a counselor. And also, but for if you're already diagnosed with it, that is, but if you're not diagnosed with depression, you have to see a psychologist to make the diagnosis, and then now go to a therapist or a counselor for management. So, aside from seeking professional help, depression is it's a diagnosis that is affected by mood. So the criteria for making a diagnosis of depression is majorly the mood and interest. So we look at usually assess past episode and in the past 2 weeks, or for how long have you been maybe sad or have you had depressive symptoms. So to manage depression, we usually advise distraction. We have distraction to just keep the patient or the client engaged so that you take your mind away from just being in that depressive state. Yeah, being in a depressive state is mostly being just sad, having this somber mood, just being there with no interest of doing the activities you used to do. So behavior activation is having, let's say, a routine or a schedule, or having a list of activities that a client can do that will engage them so that they will not be in that state. Yeah, and also encouraging, we also use motivation therapy. It works very well with our patients also with or with clients. Motivation is it's a kind of therapy that you base on what interested the client before. Yeah, just to try and rebuild that interest in them.
Mhm.
I hope I've answered the question.
Yeah, you've answered the question.
Up to
I'm
you.
just
Go
thinking,
ahead.
my wallet is depressed. I wonder if I can use all
Okay,
that
so
and then get
I
some
don't want
money
to
on it.
bore you
Anyway,
with cancer talk.
that's just me.
And
So I'll go
uh,
ahead and
yeah,
share
so
the
I made my
presentation in a
presentation as
moment.
brief as possible.
You tell
Okay,
me if you
so
have a
we're going
remedy
to
for my
have
wallet or you be the
several
best.
slides, 6 of them, and
Mhm.
yeah. So this is the overview. We're going to begin with the introduction, just explaining or defining definition of terms. And then we're going to look at predisposing factors or what causes uh, the predisposing factors. And then we're going to look at the diagnosis and psycho-oncology care, who is involved in enhancing mental wellness, and then we shall conclude from there. We can go to the next slide. Okay. So, mental wellness is a state of well-being. I hope you can hear me clearly.
Yes, we can. Yeah, clear.
So, mental wellness is a state of well-being that enables people to cope with the stresses of life and other adverse situations, whether positive or negative. I included whether positive or negative because we have a diagnosis like acute stress. Acute stress, we have positive stress and negative stress. So positive acute stress is that stress that makes you or encourages you to get up every day. It's like there are those days that you don't exactly feel like going to work, but because you have to go and attend, and because you want to keep your job, that will there's that push. So that stress around that situation is now what we call acute stress. Acute stress is actually healthy. Like it gets us to do things that it's like discipline, might I say. Yeah. So psycho-oncology is a multidisciplinary specialty focusing on the psychological and mental health care of people affected by cancer, their caregivers, and families. So this is basically the psychological support or the psychosocial support we give to the people who are affected with cancer or those that are infected with cancer, because we're either infected or affected, either way. So mental wellness is that just that ability to pull through whatever happens, because even with the positive stress that I was talking about, something like getting a new job that will require you maybe to move to a different state, a different country, a different county, that is stressful, but it's for something positive. It's for something that is not exactly a negative thing in your life. Are we together? So I hope
Yes,
we're
we are.
together.
We are together.
Okay. So, and psychoncology is basically, yeah, that can. Okay. Yeah, we can move to the next slide. Okay. So predisposing factors. Um, these are what like risk factors of what make someone develop mental illnesses. So the first one is genetic factors. Like we have genetic factors. Mental illnesses can be inherited; they are genetic, especially the ones that are chronic, the ones that we manage for the rest of the clients. Something like bipolar. We have bipolar. We have yeah. That is those are mental illnesses that we have to give patient treatment for the rest of their lives because we're just managing the symptoms. There's no cure for them. Yeah, and aside from that, have environmental factors. Environmental factors like socialization. We have where you were born and raised. Okay, not born. Where you were mostly raised, where you are socialized, how you interacted with your peers while you're growing up, things like that. So another predisposing factor is witnessing trauma or traumatic event or being diagnosed with a life-threatening illness, major life changes, loss and grief. We have this peer pressure from social media and all those things that come with them. So okay, research says that schizophrenia has a 70 to 80% of genetic irritability. Yeah, it's what I've just mentioned. So also we have these instances like witnessing an accident or being involved in one, being diagnosed with a chronic illness, if you undergo GBV, also like femicide, it can also have an impact on the society, on the friends of maybe the femicide victim, and things like that. Also, major life changes, moving, getting a new job, losing a job, or getting divorced, going through a breakup. Those things that can have an effect if not managed, they can lead to mental illnesses. So we can go to the next slide. Thank you. So how we diagnose mental illnesses? We diagnose mental illnesses by assessment tools, by using assessment tools. One of them is Beck Depression Inventory. Most of these assessment tools usually have checklists. They have items that we ask a patient or a client, and then we check whatever relates to them. And then only a psychologist can do diagnosis, and then and a psychiatrist. And then after that, the patient or the client is sent to a therapist or a counselor for management. So we also have some tools that are for adults and others are for children or kids that are from 17 years and below, well, in Kenya. But in the other countries, even from 16 years. So a 16-year-old, no, a 15-year-old and below, we use mini kid. But in Kenya, for a 17-year-old and below, we use the mini kid. And the others are for adults. Yeah, and what we assess PTSD. PTSD is post-traumatic stress disorder. This is stress that affects a patient or a client after some time after experiencing a traumatic event. Maybe, for example, someone survived an accident or underwent GBV, let's say when the year began, and then it didn't affect them as much then. But now, 5, 6 months down the line, they start getting flashbacks, or they start symptoms of PTSD, or maybe they start reliving that traumatic event. So that is the post-traumatic stress disorder. The next one is generalized anxiety disorder. This is anxiety that comes with doing routine things. The other one is social anxiety disorder. The next is agoraphobia. Social anxiety is anxiety of being in a social environment. Agoraphobia is anxiety of being in enclosed environments. AUD is alcohol use disorder. This is a disorder that comes with alcohol use. And then antisocial personality disorder, usually assess this for we have 15 years and below, just for antisocial behavior, and then 15 years and above. Okay, so mental illnesses. Also, aside from the criteria, we have to check if if maybe the stress you're experiencing, or maybe the anxiety you're experiencing, is crippling for you, or it's interfering with your daily activities. It is causing a significant clinical, social, and physical distress to a client or a patient. Because for something like depression, sometimes you can be sad maybe for a day or two because you received bad news, and then someone says, I have depression. Well, those are just depressive symptoms. And being sad is a natural emotion. So we don't count that as depression. That is just a depressive symptom, and it's a natural emotion. But now, when we are using the criteria or the assessment tools, we have that duration. Like for depression, it's for more than 2 weeks, almost every day. Your mood and your interest are very low. Then now we can diagnose that as depression. So we have to follow this criteria. Can get to the next slide. Okay. I hope you can all hear me. And
Yes, yes, we are following through.
okay. And if you have any question through any slide, you can just ask. Okay. So about psycho-oncology care, this is basically the care given to cancer patients, their caregivers, and other support systems in regard to mental well-being. So what is involved in psycho-oncology care is basically journey of the patient. Start with diagnosis for the patients that the clinicians or the doctors feel like they cannot do, or they cannot do disclosure, or they cannot break the bad news to the patients. They usually, and then aside from the follow through with the patient, so after breaking the bad news, we manage the emotions that come with them. If it's anger, if it's denial, if it's whatever emotions that are presented by the patient or the client. And then also aside from that, we also take patients through stages of processing information or processing bad information, because we all take, I mean, we are different. There's some that you can receive bad news, Sahi, something like, let me use the oncology. For there are some patients that we tell them that you have cancer, and they go straight to acceptance. They ask, okay, so what's next? What should we do next? What treatment are we getting? There are some even walk out. Some get so angry that they can even beat you up. But I mean, you manage. Um, some get to denial. Some just go mute for a while. Yeah, so everyone receives this news differently. So even as we take them through the stages of processing bad information, we cover all that. And then aside from that, we also journey with the caregivers because caregivers sacrifice a lot, especially for the new diagnosis and for the treatments that take even up to 5 years because this is a chronic illness. We are staying with the patient for as long as they can sustain the treatment. So we also journey with the patient because even as the patient is processing all this, the caregiver also has a role to play, like to provide for the patient, to get the patient to the hospital to get treatment, care for the patients with the side effects, give medication, follow up with the doctors about the treatment. And there are times the patients get irritable because maybe they've not come to terms with the diagnosis or they feel like the caregivers have ulterior motives. So there's a whole situation going on there. So we also journey with the patient, especially spouses and children of patients. They go through a lot. And also there's the financial bit. So yeah, we have to journey with them as well. So also another uh, care tip is we also assess the patients now for different psychological diagnosis and management. Yeah, in this process, as we assess the patient, these adverse situations in our lives, they usually magnify um, any other underlying mental illness. So if maybe someone, we also have personalities playing in the care and in how patients receive all these news. So if a patient has been irritable without the cancer, it's going to double. If the patient has been maybe undergoing a mental illness treatment or management, it's going to be magnified. If maybe the patient has alcohol use disorder, this is going to be magnified. Yeah, so now we have to assess, and after getting the diagnosis, we do management. And then, yeah, I think I've covered. Yeah, and also manage any other concerns of the patient and the caregivers, and also any other support system, like maybe the neighbor, no, not neighbors. Let's say distant family, friends. Some come with their friends because when the diagnosis came, there was blame game, there was a lot of things came with them. So now we also have to journey with them. Okay. So, who is involved in enhancing mental wellness? Uh, Everyone, all of us have a role to play in mental wellness enhancement. Even as we do the assessment of the patients, with everything else plays out from the first person this client or this patient needs. Even with here, if we go to let's say a public office and we want maybe the e-citizens, the passports, the all those services, and we get someone who is mean, Kwamlango, be salty, you are going we are all going to turn salty, we're all going to be irritated. Even we can even start transferring aggression to the ones who were not even involved with what you received while you got there. So primarily, whoever is in contact with the client or the patient, and anyone can be a client. So meaning everyone who is in contact with everyone has a role to play in maintaining the mental wellness of the other person. Of course, in management of the mental illnesses, a professional has to do the same so that we can give skills to the patient or client. Um, Yeah, I think the rest is self-explanatory. It's just to, it's just basic humanity. We're at conclusion. So yeah. So conclusion, mental well-being starts with you and I. Just as we go for for medical checkups, mental checkups is as important. We have this myth that we only see a psychologist or a therapist when maybe we are almost running mad, or when we are going to be confined in a hospital, or when we're addicted to something. Well, that is not the case. Your mental well being is as important as your physical well being. Life happens vastly every day, and occurrences can put one in a place of risk of developing mental illness. Yeah, so that is also self explanatory. Cancer and every other condition can either infect or affect. Even though you are not diagnosed with cancer, you have maybe a friend, a relative, even I'm sure every one of us has heard about cancer. Hata kama it's in the news, wakiongelea what to do. So we're all in this society and we are affected in one way or another. So let us all be vigilant about our general well-being, because there is no health without mental health. Thank you.
Wonderful, wonderful.